Assalamu alaikum. Welcome everybody. Thank you for staying for this talk. Can I just get a show of hands before we start? Has anybody ever had a patient die in their emergency department from renal colic? No. Has anybody had in their department somebody die from a condition that was misinterpreted as renal colic? Okay, fantastic. So what's the issue? We're always looking for some other diagnosis, because what we know is if somebody's got pretty classic renal colic, and if they're a relatively young person and they've got frank hematuria and their onset is pretty characteristic, we know that's pretty much renal colic, okay? But the real issue is that if you've got an older person, somebody who's in their 70s, and they've got back pain, even if they got hematuria, plus or minus abdominal pain, you don't know, is that what? What could that be? AAA. I mean, that's emergency medicine 101, isn't it? So it's AAA is the first thing. But what other disasters are waiting the abdomen for the unsuspecting person who's thinking this is a renal colic? Diverticulitis, perforation, appendicitis. So there's lots and lots of reasons why we actually look at imaging, and the stone scoring going to go through that. But before we get through that, I don't have any disclosures except academic disclosures. And the one thing to say is when you go searching for the stone score, there are 6 stone scores that I found online over the past couple of months, and the one that we're talking about today is this one. All the other stone scores do not relate to emergency medicine practice per se. So this was the derivation and validation of a clinical prediction rule for uncomplicated urethral stone. And they were going to look at something prospective and then prospective to see could they predict what were those clinical factors that would make a score so high that this was absolutely renal ureteric stone and you didn't have to worry about other imaging. Okay? So what they wanted to do was to find out what were those risk factors. And they brought it down to 5 specific features. And they were male sex, whether the onset of the pain was acute, a very classical sort of pain, whether somebody's ethnic origin was non-black in this study, whether there was nausea and vomiting associated, and whether or not there were red blood cells in urine microscopy. Now, that seems like that's what you would be doing to make your normal assessment anyway of renal colic, isn't it? If you did that, wouldn't you say, yeah, if somebody's positive for all those, that sounds like renal colic? So what they want to do is to retrospectively look at approximately 1,000 charts, and they looked at all of these charts and said, well, like, if they've got that picture, and they've got a high score, and the score when you actually do it out is out of 13. When you have this score, and somebody scores 13 or 10 to 13, does that person have a renal stone, and thus do they really need imaging? And surprisingly enough, they found, yeah, sure, you've got a high score, you've got a very high chance of renal colic. But what they really were trying to do is say, did you have a risk of having other occult pathology as opposed to a stone? Okay, so could it have been a AAA? So that mirrored what they were looking at. So they looked at all of the charts beforehand, and then they prospectively used that score going forward to see was there an association. And they said, yeah, it was very good at predicting whether you were in a high score, 10 to 13, or a low score, a medium score. It determined whether this was more likely to be a stone or not. However, in the paper, there were cases missed. Now, they're not a huge number of cases, but when you look at all the patients that were there, it turned out to be about 0.3 of the entire study population. But the issue was that the cases that were missed were things like appendicitis and diverticulitis. So what's the problem if you think somebody has appendicitis, if you think somebody has a ureteric stone, and it turns out that it's appendicitis or diverticulitis? What's the problem? General things. Different treatment. It really is as simple as that. So technically, for the majority of people who've got a renal stone, ureteric stone, they're generally going to pass the stone and they generally don't suffer any complications. However, if you've got diverticulitis or appendicitis, you have high risk of other complications. Infection, sepsis, infertility, a bunch of other things. And that's the issue, that you still risk the missing some of these cases. This paper was validated, though, afterwards to see was that predictor, low, medium, high score, did it actually accurately predict that you had a good chance of having only a ureteric stone as your diagnosis? And the same thing was found in this paper. Subsequently, to the first original paper, this was looked at and said, yeah, look, it's slightly superior to physician's gestalt. But let's be realistic. If somebody walks into you today, and he's a 28-year-old guy, and he comes in with bad flank pain, it's literally come on within a few minutes, and it's severe, the worst ever pain he's had. He's nauseated with that. He's feeling very unwell. The pain is severe. He's got blood in his urine, and he's a non-black American as per their study. What is the likely diagnosis there? It's likely renal colic. So have we actually gained anything extra by this? No. And has it actually allowed us to actually not do a study? Now, we generally want to do CAT scans, and the number of CAT scans has gone up exponentially in the States. So from the 1990s, CAT scan became the diagnostic tool of choice for patients with suspected renal colic. But why was that the case? It was the case because it picked up alternative diagnoses. Okay? So the argument then is, well, maybe we're just overdoing the scans. And yes, in the States they are. So for the 5-fold increase in scans for renal colic that they've done in the past 30 years, there's been 0 increase in the rate of detection of renal stones. So it's a tool that is not, it's overused for diagnosing renal colic, but it is probably appropriately used, or maybe slightly overused, for picking up occult other pathology. So then you say to yourself, is CT-KUB the diagnostic tool of choice? And then when you look at things in general, it's a low-dose CAT scan. It's a low-dose radiation. It's lower dose than a CT urogram, and it's lower dose than a regular CAT scan that needs oral and IV contrast. And the other benefit of CT-KUB is it's really, really, really quick to do. It can be done at any time. So maybe you might look at using the stone score instead to say, okay, let's try and risk stratify those people that have alternative diagnosis. And those people who are in the very low score and who are over a particular age, maybe they're the people that we should be looking at scanning. But that's not what the paper had looked at. This paper was external validation of stone and derivation of a modified stone score. And what this paper did was this looked at the initial stone score, and thereafter it said, well, look, we've got all those factors. Was there anything else that could have made the diagnosis a little bit clearer and could have made it a little bit easier for us to understand an alternative diagnosis? And that paper said, yeah, look, it was the initial stone score was probably very accurate, but what happened afterwards was they said, but look, if we use CRP and a previous history to replace the nausea and vomiting and racial predictors, maybe that would be better. Now, this is where I think it loses its credibility, because what we as clinicians want, we want those simple, easy, calculatable scores that we can actually use, calculate in our heads, like what Colin was saying earlier on, the indices that we're looking at. You want to be able to look at those, calculate them quickly and say, yes, this person has a likelihood of something, and thus we're going to do a scan. Similarly, if you think about well score for DVT and PE, okay, that's a good score, but you need to have your pre-test probability high. You need to have a high index of suspicion to begin with, and then the scores work. So is this really adding anything different to my practice? Well, certainly, if I need to do a CRP, I'm already saying to myself, I'm doubting the diagnosis. So therefore, doing a CT-KUB is probably not the right test to be doing. I am probably better doing a CT urogram, or ideally even a CT abdomen is a better test. Okay? Now, I do appreciate that worldwide access to certain tests is very, very difficult and they're costly. But if you were to do one test, why not do the right test for somebody straight up? So, is the score relevant to emergency medicine? Well, the validation of those the following studies showed it was not exactly exact, and it lacked sufficient accuracy to allow clinicians to defer doing CAT scan for suspected renal stone, and more importantly, for alternative diagnosis. But it can help confirm your original gestalt. In a subsequent publication about the emergency medical cases from Canada, it was in the well-appearing patient, stable vital signs and normal clinical picture, further diagnostic imaging was not necessarily an issue. And then you start to say to yourself, well, do I need to do a CAT scan at all in these patients? Well, maybe not. If it's an absolute classic picture, maybe you're better, first up, just doing a renal ultrasound. Because why I want to do a renal ultrasound, I want to check that there's no hydronephrosis because of obstruction. If there's an obstructive stone, you've got an increased risk of sepsis and an increased risk of renal failure as a result of that. So that's probably a simple, non-invasive, non-radiological test that can be done, even potentially at the bedside, if we have our physicians trained up well enough for that. So the bottom line for them was they found that first-time renal colic should have an ultrasound first, and then, if required thereafter, a CT scan if the initial test was inconclusive. I'd like to thank Alan Batt, who's one of my research collaborators in Canada at the moment. But I just go back to the original paper and just bear in mind that it's a great idea, but sometimes trying to get a score to validate what we do as clinical practice, we're just doing what we normally do, and it's just putting numbers on things. Have an appropriate pretest probability first, because all of those scores are just validating what you're doing clinically based on all your years of experience as well. Thank you very much.
Thank you, Professor.